I'm K.D. Weeks, Editor-in-Chief of the Cardiosaurus Clinical Community on Sleep Apnea and Cardiovascular Disease. It's a pleasure today to introduce Dr. Virend Somers, MD, Professor of Medicine, and lead author of the ACC and AHA Scientific Statement on Sleep Apnea and Heart Disease from 2008. Dr. Somers, thanks for being with us today. I'd like to start by asking you if you would talk briefly about the relationship between sleep apnea and heart failure.
Well, first, Ken, thanks for inviting me to talk with you today. We have to think of sleep apnea and heart failure first as the interaction between sleep and heart failure. And if we think back onto the classic heart failure symptoms, orthopnea, paroxysmal nocturnal dyspnea, fatigue, those symptoms which we attribute to heart failure really also are very closely associated with sleep. It's shortness of breath when you lie flat, shortness of breath that wakes you up in the middle of the night, and tiredness perhaps from getting inadequate sleep. So we have to understand the sleep-heart failure relationship has been present for a long time. It's really over the last maybe 20 years or so that we've begun to recognize the true implications of that relationship. And one of those implications is sleep apnea, both obstructive and central. And it's important when we think of sleep apnea to recognize that there's really two major kinds of apnea. Central apnea, which is a kind of apnea that we talk of when we talk about Cheyne-Stokes breathing, and then obstructive apnea, which is a more louder, active type of apnea where the obstruction to breathing is due to collapse of the upper airway. Now, both obstructive and central apnea have been linked to heart disease. And the mechanisms are multiple. We think it may be linked to high levels of sympathetic drive, to release of substances like endothelin and other vasoconstrictors during apneic episodes, as well as we think to the fact that these patients are just not getting enough good quality sleep, which has carryover effects into the daytime.
How prevalent are these apnea spells in heart failure patients?
So when we think about obstructive apnea, on average it would affect about maybe 20 to 25% of the heart failure population. The caveat here is that it depends on the body habitus of the heart failure population. For example, if you have a population in Europe where the heart failure patients may tend to be leaner, a lower BMI, they would have less obstructive apnea. If you take a population in North America where patients tend to be more overweight, more obese, they tend to have a higher prevalence of obstructive sleep apnea. Now, central sleep apnea, we think, affects maybe about 30 to 40% of the heart failure population. Again, this depends on the nature of the population you're studying. In a VA population that's predominantly male, we're going to see a higher likelihood of central sleep apnea. And in a population that's leaner, central apnea tends to be more prevalent in heart failure setting.
What are some of the more problematic issues that describe the effects of obstructive sleep apnea in heart failure patients and the mechanism?
Well, I think to understand that in more detail, we have to know first what happens during normal sleep. And what we find on the first slide is that during normal sleep, there's a gradual reduction in sympathetic activity, in heart rate, and in blood pressure. And this reduction is progressive through the deeper stages of what we call non-REM sleep. So as you go through stage 2, 3, and 4 sleep, we tend to have a decrease in blood pressure, a decrease in heart rate, and a decrease in sympathetic activity. During REM, when people are more likely to be dreaming, sympathetic activity is much higher. Now, this is actually totally normal, totally physiologic. The problem is in patients with obstructive sleep apnea, that physiologic interaction between state changes in the brain and cardiovascular function is lost. The entire neural circulatory response in apneic patients is dictated primarily by the presence of the apneas. And in the second slide, you see recordings in obstructive apneic patients who are wide awake. They're breathing normally, they're completely healthy otherwise. And as you can tell, the ones with obstructive apnea on the right have very high levels of sympathetic drive. Now, these people are healthy, but the levels of sympathetic activation that they manifest are very similar to what we see in heart failure patients. Now, it gets worse when they go to sleep, and in the next slide, you see the progression of changes in sympathetic activity and intra-arterial blood pressure in an otherwise healthy subject who has obstructive sleep apnea. And you see in the top left-hand corner high levels of sympathetic drive. The patient has obstructive apnea. During obstructive apneic episodes, you will see a progressive increase in sympathetic activity, and this is driven by the chemoreflex. This sympathetic vasoconstriction raises his intra-arterial blood pressures to levels as high as 240 over 130. And this happens repetitively during the night. And then when we treat the patient with CPAP, you see a reduction in blood pressure, a reduction in sympathetic drive, and a general improvement of cardiovascular physiology. So you can imagine that this kind of stress, this kind of autonomic, of adrenergic, of hypoxemic, hypercapnic, and pressor stresses in a patient with heart failure can potentially progressively worsen cardiovascular function and maybe eventually take the heart failure patient into a non-responsive, poorly controlled heart failure situation.
You mentioned central sleep apnea. How is it linked to the poor outcomes we see in heart failure?
So central apnea has effects that are similar to some extent to obstructive apnea with the following caveats. First, central apnea has less of a hypoxemic stress. So the degree of hypoxemia in central apnea tends to be less than that which you'd see in severe obstructive apnea. The second thing that characterizes central apnea is they don't really have an increase in carbon dioxide levels. In fact, one of the ways that you can identify patients with heart failure who have a high risk of central apnea is to look at their arterial CO2s. If CO2s are low, that means they have a significant risk of having central apnea. These patients do, however, experience repeated arousals during sleep. Even though they don't know they're waking up, the brain will actually manifest an arousal, an electroencephalographic arousal. So they do have disrupted sleep. Now, the big question, though, is we know that patients who have heart failure and have central apnea are much more likely to have a poor outcome. They have a higher mortality. And this has been consistent through a number of studies. What we don't know is whether central sleep apnea is actually the mediator of that poorer prognosis. And so this is a very important area that's being investigated, and part of the ways of answering that question is to actually do randomized clinical trials treating and preventing the central sleep apnea to see if outcome improves. Now, I should also mention that we see central apnea even in patients with asymptomatic left ventricular dysfunction. And the thinking, although that also has not yet been proven, is that maybe if you have central apnea and asymptomatic left ventricular dysfunction, that central apnea will push the LV dysfunction patient eventually into overt heart failure. But that's pure hypothesis at this time.
Tell me about the options for therapy and cardiovascular outcomes and the different options for treatment that we have.
So let's talk about obstructive apnea. Now, if a patient has obstructive apnea, they have heart failure, we'll do the standard obstructive apnea treatment steps. You try to get them to lose weight if they can. Have them sleep on their side, because obstructive apnea is due to loss of airway tone, and when people sleep on their backs, the lower jaw falls backwards into the airway, causing the tongue to obstruct the airway. So by sleeping on your side, you tend to avoid that problem. The classic treatment, though, is what we call continuous positive airway pressure, which is a column of positive pressure that splints the airway open, thus overcoming the airway obstruction. Now, there are more recent experimental approaches to obstructive apnea that are being developed. For example, neural stimulator mechanisms that try to activate the nerves that control the upper airway, thus enabling you to keep the tongue out of the airway when you're breathing. But those are, again, very experimental areas right now, and we still need to see if they actually do make a difference to obstructive apnea and do affect outcome. And that's a very important question. Do they affect outcome? At this time, what we do know is that if you treat obstructive apnea patients with heart failure, you could lower blood pressure, you could improve ejection fraction, and you could perhaps improve their symptom status. What we don't know is whether we will decrease mortality and decrease hospitalizations. And by the way, the same is true for central apnea. We don't know whether treating central apnea will improve mortality and decrease hospitalizations. And it's important to point out that I'm actually on the steering committee in terms of conflicts of interest, on the steering committee of a trial that's actually asking that particular question. Does treating central sleep apnea in heart failure actually decrease mortality? Now, what are the options for treating central apnea? We used to use CPAP, continuous positive airway pressure, but intuitively that does not feel like the most appropriate treatment for someone who's not breathing. And so there are newer positive pressure options that are available, one of which is adaptive servoventilation. Other experimental areas in terms of treating central apnea include cardiac resynchronization therapy. There are some preliminary data suggesting that if you take a patient with heart failure who needs CRT, that if you provide the CRT, there is a decrease in mitral regurgitation, improvement in forward output, and an associated decrease in the severity of central apnea. Now, in terms of experimental approaches that are on the horizon, one of these is a method of stimulating the diaphragm to improve breathing.
Thank you very much. We'll need to wrap up now, and thank you for your insights and contributions of your previous vast research and education in sleep. Thanks for being with us today, Dr. Somers.
Thanks very much, Kent. I appreciate the opportunity.